as I said, you have found your way to the protective factors and ACEs, meeting families with hope and healing. And if you think of it this way, as ACEs screenings become more widespread, providers might lack knowledge about engaging families in the screening process in a way that supports healing within a data-informed framework. So our presenters are here today to talk to you a little bit more about that. And on our next slide, you'll see who they are. We are so excited, actually, some repeats. We're so grateful to have you both with us. I know they're going to give a much better introduction than I could do. So with that, I would pass it off to Katie and Malcolm. Thank you both for being here. We're so excited about today's topic.
Thank you so much. We're looking forward to our conversation today. I am so grateful to Caltrin for including us in their series and the focus on family resource centers. I'm Katie Albright. I'm a former CEO of Safe and Sound, and I'm currently serving as a senior advisor. I've been in this field for over 16 years, supporting children and families, and prior to that was an attorney working with the city and county of San Francisco. So that's just a brief bio of me, and we'll get into much more about Safe and Sound, and I'll turn it over to Malcolm.
Thanks, Katie. My name is Malcolm Gaines. I am the Senior Clinical Projects Director at Safe and Sound. I've worked at Safe and Sound for about 20 years in various roles, so really feel very invested in our work supporting families and preventing child abuse. And I have the pleasure of presenting with Katie today. It's always a pleasure doing that with you, so I'm happy to be here today. So I'm going to go through a couple of introductory slides, and then we're going to jump into our content. So goals for today, we want to set a little bit of context for this discussion of using protective factors and ACEs in a sort of integrated way. And the context that we want to set is thinking about building community pathways for community support within the context of child welfare reform and some desired reforms in mandated reporting law and practice. Katie is going to set that context for us. And then we're going to talk together about and develop some shared language around community, family level and community level protective factors, and the relationship that we think exists between the protective factors framework and adverse childhood experiences science, and then consider together how this framework can be used mostly in a family support setting, but in other settings as well. So that's where we're headed today. Next slide, please. This is how we're going to do it. We've got some introductions. We're going to talk with you about the ecological model of primary prevention that we and many other family resource centers use, and then we'll go through the rest of the material. Next slide, please. We want to acknowledge our many partners that have really supported us through the years of building this work together, collecting the research, providing the research, providing some funding for all of this work. We'll acknowledge these partners throughout the slide deck as we go through. Next slide, please. Okay, Katie, I think you're up. Thanks.
Thanks so much, and I'm really looking forward to this presentation with you as well, Malcolm. We've done this several times, and we're looking forward to sharing and hope that this is an engaging conversation. So we will be providing the PowerPoint. There's a lot of information in it, so we might not go through every detail on the slides, but you'll have it as reference afterwards, and certainly the recording will be available. Please use the chat and the Q&A function, and we'll try to get to as many of your comments and questions as we go throughout. In terms of, I'm going to be presenting for a few slides. Malcolm just went off on video. He'll come back. I'll go off on video just so it's less distracting, so you're only seeing one person. But let me start with sharing more about Safe and Sound. We were founded 50 years ago this year with a mission to support children, parents, and communities. We began our work as a San Francisco Child Abuse Prevention Center. In addition to serving as our county's CAPC, we have evolved through the years of creating a family resource center, family support center with a 24/7 warm line. We partnered with our county to be a children's advocacy center. We work in partnership with other counties throughout California, particularly in the Bay Area. I know there are many on this call that are not from California, and we'll do our best to provide reference to what's happening both in the state as well as out of the state. We're a member of the Citizens Review Panel and our Early Intervention Committee as well. So we think about this work that we are front row, have front seats in it, and we understand both our role as mandated reporters and trainers of mandated reporting through our Child Abuse Prevention Council, as well as being complicit in the system that is inequitable and oppressive to many. And we'll be talking about that a little bit more. I wanted to start by talking about our ecological framework that we have on the slide. We are so focused on putting children at the center of our work, but certainly children are stronger with families. And we focus, as Malcolm said, on building protective factors with families. And we'll be talking about that a great deal. And families live in communities. So we think about how do we build safe and strong communities that take action to support families, and communities are part of systems, systems that we want to ensure interconnected and strong and a healthy society as well. And so Safe and Sound works at each one of these rings in terms of our work, and that's how we frame our work in particular. I'm going to start the presentation really focusing on those outer rings. What does the system, the context in California look like? We'll then go to, Malcolm's going to talk more about individual level outcomes as we think about adverse childhood experiences, and then we'll come back out a little bit and do more around community outcomes. So we wanted to show this slide, one, because we deeply believe that in order to mitigate adverse childhood experiences and child abuse, we need to be working at each one of these levels, this individual level, this community level, this systems and societal level. And that's the critical framework for our work, as well as this presentation. So again, as context setting, I'm going to start a little bit talking about California. I know that many are not from California, but it's important that you understand the context and the numbers and the children with whom and the data with whom we really think about our work. So when in talking about child abuse and neglect, which are some of the most critical ACEs, adverse childhood experiences, we are specifically talking about the legal definition in California: neglect, physical abuse, emotional abuse, and sexual abuse. In California, there are most recent data of 2022. There were approximately 450,000 children with a report, an allegation of child abuse in our state. That's approximately one child who's reported every 2 minutes in our state. Of those 450,000 reports, our child welfare county partners throughout the state substantiated 51,000, a little bit more than 51,000 cases of child abuse, and that included 108 child fatalities. These are the children that we know about, but there are so many more that we don't know about because of underreporting. So this is a pictorial representation of these numbers, reports, substantiations, and fatalities, and those larger, darker blue dots are actually approximation of the number of children that we don't know about. The impacts of abuse are significant to the child, to the family, and the community. And I wanted to share those with you in a little bit more detail. Victims of child abuse are more likely to fail in school, lead riskier lives, experience chronic medical, mental health, and substance abuse problems in childhood and in adulthood. And child trauma poses a significant barrier to health issues. That's what we are talking about with adverse childhood experiences, long-term health issues, as well as you can see in this slide, economic self-sufficiency. In addition to the impact on the child, there's certainly impact on families. Not all families experience generational cycles of abuse. However, the research does suggest that violence perpetuates generation from generation based on neurological, social attachment, and ecological based theories. Some of the most recent evidence talks about a 25 to 30% of individuals who experienced abuse as a child may grow up and continue that cycle into adulthood. Importantly for this conversation, the impact is not just on the child and the family, the impact is on the community as well. We all pay the price of child abuse, child maltreatment, adverse childhood experiences. Child abuse is a key contributor to many of the social issues that we as a community are struggling with: underperforming schools, homelessness, high rates of incarceration, increased drug use, alcohol use, lack of workforce vitality, and the list continues. What's important to understand is that, again, we all pay that price. In fact, if you aggregate all the costs of child abuse, the Center for Disease Control has measured that the overall cost is $124 billion, is actually higher. More recent research includes that to be higher. We at Safe and Sound have worked with the Haas School of Business at Berkeley and measured that using the same analysis that the Center for Disease Control used for the United States, that in the most recent data, the most recent year of 2022 that we have available data, that cost to California is $24.4 billion. And you can see from this slide, we've also measured the cost in the Bay Area as well as the cost in San Francisco. $24.4 billion. That number is so crazy big. I can't, it's hard for me to get my head around it. So what that number represents is we could send all the children in California to preschool that are eligible, 3 and 4 year olds, and we'd still have enough money to send some of them to college. So that's why we are so focused on this work, because prevention, and you'll hear me say at this end, child abuse costs, but prevention pays. And that's why it's so critical that we think about prevention, and as Malcolm said, think about the development of that community pathway. I want to break these numbers down a little bit more so you have a context, and these numbers are relative throughout other jurisdictions in our country. Of those cases that I just talked about for 2022, 47% of all children were neglect cases. So a substantial number of these cases are neglect. Of those neglect cases, of all those cases, a substantial number are disproportionately impacting children under the age of 1. And of concern that even though we know child maltreatment bounds no zip codes, economic status, race, or ethnicity, because of systemic and structural racism, children of color are disproportionately represented at every critical point in that child welfare pathway. In California, and again, these are numbers that actually are similar and in jurisdictions throughout our country. 25% of white children in California are investigated for a case of abuse and neglect by the time they're age 18. I'm gonna let that number sort of sink in a little bit more. And that compares, even more concerning, that 50% of Black and Native American children are investigated by that same time. This graph, and that was just investigation. This graph talks about substantiations. So Black, Native American children are 3 times, this is California, but again, it's consistent across our country. Black and Native American children are 3 times more likely to be substantiated as a victim of maltreatment than white children, and Latinx 1.5 times more likely. Again, these disparities are happening because of a complexity of factors, structural and systemic racism, implicit and explicit bias. And I know that these numbers are difficult to hear, particularly because we know that behind each one of these numbers is a child, a parent, and a caregiver. It's because of this data that Safe and Sound and others throughout the country are really thinking about how can we move this work more upstream? How can we think about prevention? How can we create a paradigm shift? And you see this, this issue brief that Safe and Sound created in September of last year, really calling for a paradigm shift. Policymakers are seeing the need from this shift. Certainly when we think about the landmark legislation around Families First Prevention Services Act, and in California, we have the many of our counties, most of our counties are working on prevention plans and an initiative to create these community pathways. These community pathways that will mitigate child abuse, will mitigate adverse childhood experiences. And so I wanted to go a little bit in depth before turning it over to Malcolm about this issue brief and talk about just an overview of some of the recommendations that we're calling for. One of the reasons why, in addition to the data that motivated us to do this work, is because of parents and caregivers like Shelley Lopez. I had the honor of working with Shelley. She's a survivor, a parent advocate, and now a mandated reporter who lives in California. And she was kind enough to share, I feel privileged for her to share her personal story with me and allow me to share her words today. You see it on the slide, and I'll just reference a couple of the words. Again, her daughter was born medically fragile and she had no support from her family. When the police called Child Protective Services, she had no idea that my child could be removed because I was a victim of domestic violence. How could they take her away? I believe my experience and my daughter's life would have been different if we had had support, if someone had explained the failure to protect laws. Even though my daughter was in foster care for less than a year, she continues to suffer from the experience. It's because of people like Shelley, parents like Shelley, that the momentum is changing around how do we think about adverse childhood experiences? How do we think about reporting and our role in the community as community supporters, not just mandated reporters? How do we develop this community pathway? So I'm going to just run through a couple slides relatively quickly and then turn it over to Malcolm to talk more about what the development of a community pathway might look like. This paradigm shift is not just being called for by parents and caregivers like Shelley, but policymakers and advocates who are calling for the shift to truly support the work to be for well-being of children and families. Understanding that there are inequities and understanding that we need transparency in the system. Those that are working in child welfare, as you can see from this slide, whether in government or community agencies, are shocked by the data of disproportionality and also calling for a change. Mandated reporters are currently feeling like they work in a fear-based system, one based on surveillance. Families fear that they're going to be reported and their children removed, and a mandated reporter's fear of the responsibility and liability for not reporting. Mandated reporters want to support families, but recognize that the system is currently not structured to help foster those supportive relationships, as you can see from this slide. And again, I know this is a lot of information on the slide, and we'll be sharing it out with you so you have it. And mandated reporters are calling for this pathway that we're going to spend more time talking about. In addition, in California, the Citizens Review Panel on which I sit and others throughout California sit have called for recommendations to look at our mandated reporting system and change and think about what does it look like to go from mandated reporting to community supporting. And so in this issue brief, Safe and Sound has put forth several different recommendations. The recommendations are focused on embracing a trauma-informed framework and really beginning to ask not what's wrong with you, but what happened to you, and thinking about how can we help families? What are the resources that families need? How can we focus on family strengths, not just the negative sides, but the strength sides that families are. And if we think about that, we think about the importance of family resource centers. We think about the importance of creating this community pathway, one that's trauma informed, one that invests in basic concrete supports. We're also recommending that we look at changing the definitions of neglect, really understanding that definition of neglect. And with legislation that the governor in California passed last year, AB 2085, SB 1085, really narrowing the definition so that poverty is not included as part of the definition of neglect. That's already happening. And you can see from this slide that there are other opportunities policy-wise and legislatively to think about this reform and this paradigm shift. A significant piece of this is the importance of family resource centers. Data shows that family resource centers are effective. There's a 45% reduction in cases of child abuse and neglect, and a significant return on investment from data just in California. And you can see from the slide data from Orange County, Shasta County, and Sacramento, really underscoring the efficacy of family resource centers. And I know many of you are in family resource centers or partnering with family resource centers, and it's critical to understand how important they are to our whole paradigm shift and work. In addition, we are recommending that we begin using and thinking about different ways of identifying and reporting and working with peers and partners when we have a case of child abuse, whether or not maybe there's opportunities for group decision makings or opportunity for people to do an equity check, which is really important. Invest in technology solutions so that we can connect families together with supportive services, which is going to be so critical. In addition, this is going to take significant training and change, thanks to our partners at Caltrans, are going to be critical in changing all of our mindsets. And how do we think about training of us as mandated reporters? Because I know many of you are mandated reporters on the call, and you know how difficult it is to make that report. And so as we think about changing the paradigm at the systems level, that means changing the way we work at an individual and a supporter level. It's going to be incredible and critical to do. And again, all of this work is going to be led and guided by communities, tribal nations, and other stakeholders to help us understand and put forward and promote those with lived experiences so that we get this right and we don't perpetuate further harm in creating systems change. The momentum continues in this. Our California Child Welfare Council has approved recommendations to pull together a task force to begin looking at mandated reporter to community reporter shifts. The California Department of Social Services, CDSS, has adopted or incorporated many of the recommendations of the Citizens Review Panel to collaborate with the task force, to update the reporter trainings, to think about cross-departmental conversations and research to move this work forward. And there are incredible examples happening in counties throughout California, both north and south and east and west, Humboldt, Los Angeles, Sacramento, San Diego, San Francisco, and Ventura, just to name a few. So that's the overall context from a policy level, again, working at that outer ring. And now I'm going to pass it on to Malcolm, who's going to talk more about the work happening internally, those individual and community level rings. Malcolm, I'll turn it over to you.
Thanks so much, Katie. So what we're aiming for here in our presentation is to support your thinking about how you might implement using the protective factors framework and an ACEs framework, balancing risk and strength, in the context of building community resources, building family support centers, building the web of support. That is a key part of this these set of recommendations, right? There are policy changes and all of that needs to be made. And what we're really homing in on today is, as practitioners and program directors and program designers and directors of family resource centers, how can we implement, continue to do our work, the good work that we already do, and do it in a way that that builds and supports this community pathway. Okay, so next slide. Let's start with a little bit of context for that. I want to talk about how, really, in my experience at Safe and Sound, and I'm curious to hear if other folks would, who work in family resource centers, would frame it differently. It's really trauma recovery work for the most part. Not every minute of it, but the larger context of it is. And so what we're talking about is implementing the protective factors framework in the midst of trauma-informed care principles, establishing and maintaining physical and emotional safety, building trust, right? This is a relational model, recognizing trauma as trauma and not just something that's wrong with someone, but that is a result of something that happened to them or that is happening for them, right? Patient-centered, evidence-based work. All of these trauma-informed care principles are essential not background, but they're embedded in the way that we need to implement the protective factors and ACEs screenings. Next slide, please. Another piece of this is to think about phases of trauma recovery. When you think about trauma recovery work, there are lots of different sort of phase models to think about it, but they all really essentially include these 4 elements. And they happen essentially in pretty much in order. You can't do trauma processing work without these other steps beforehand: building safety and stabilization, building skills and strengths. And I want to say that whether you are think of yourself or as a mental health professional that sort of does that trauma processing work, or whether you are somebody else, have another role in a family resource center that supports safety in families, stabilization in families, building skills and strengths, that is participation in the trauma recovery process. And so we need to, I just want to offer that framing to locate what we're doing here within this recovery model. Next slide, please. Okay, so let's do a review. It's probably a review for most of you, but it could be an introduction for some of you of adverse childhood experiences and the ACEs study. Next slide, please. What are adverse childhood experiences? So we think of them as stressful or traumatic experiences that people have had by age 18. They were originally identified and sort of named in the study back in the 90s, done by the Centers for Disease Control and Prevention and in Kaiser, that really identified 10 categories of individual level ACEs, things that individuals could have experienced in 3 domains: abuse, neglect, or household dysfunction. And they did a correlation of, in the Kaiser Permanente medical records, they were able to use this large data set with medical records from Kaiser Permanente to identify experiences that people had reported earlier in their life and correlate them with negative health and mental health outcomes later in life. And of course, what they found astounded them was that the correlation was so significant beyond anything they even imagined. We already knew, right, sort of intuitively, that early experiences affect later outcomes in life. And that makes a lot of sense. But this was really the first time that this kind of quantitative evidence was provided that we could work with in a science-based way and add some quantitative knowledge to the qualitative knowledge that we already had about this. So originally they identified 10 particular experiences, but subsequent research, I mean, it's been 30 years since then, subsequent research has identified more individual and community level experiences that intensify the effects of the original 10 ACEs. Next slide, please. Here's a list of the ACEs that they studied. what got added to what has been added to these are community level experiences. Katie's going to talk more about that at the end of the presentation when we go back out into the outer ring of that ecological model, out into the community. But when we think about more individual level experiences, these are the 10 that were originally studied. But what we know is that community experiences like community violence, felt discrimination and oppression, many other of the sociocultural negative sociocultural forces that act on us and our families, particularly communities of color, poverty, those are also experiences that are adverse, and they magnify the effect of these 10 original ACEs. Next slide, please. We know that ACEs are very prevalent in the population. 62% of Californians, from research that was done some years ago, have experienced at least one ACE, but 16% of Californians have experienced 4 or more ACEs. And if you look at the ACEs research, that number, that sort of 4 number, is sort of the magic number. Once you hit 4 or more ACEs, the correlations with negative health outcomes really skyrocket. Next slide, please. ACEs dramatically increase the risk for at least 9 of the 10 leading causes of death in the US. So for folks that have, again, there's that sort of magic number 4, for folks that have 4 or more ACEs, compared with people who have no ACEs in this research, these 10 leading causes of death, you can see how much more likely it is that someone will experience these medical issues and mental health issues if they have 4 or more ACEs. Twice as likely to experience heart disease, more than twice as likely to experience cancer. I'm not going to read the whole thing, but if we get down to Alzheimer's or dementia, 11 times more likely to experience that later in life. 37.5 times more likely to attempt suicide if you have experienced 4 or more ACEs. The numbers just continue and the list is long, but just to emphasize that ACEs science really provides us with a way of understanding more clearly how important it is to prevent child abuse, to prevent other sources of toxic stress in a child's life. Next slide, please. So if we take a look at ACEs, and we'll take a look at ACEs screenings and that practice a little bit later on, but I wanted to sort of outline ACEs. I'm going to put that there, and now we're going to look at the 5 protective factors and sort of put that next to ACEs and ACEs science and see what we come up with. Next slide, please. So the 5 protective factors framework comes out of some research that was done a little more than 20 years ago by the Center for the Study of Social Policy. It's also known as the Strengthening Families Framework. You may have been trained in this already. The research was done in early childhood education settings. And in general, what was found was that populations of families in those settings with lower rates of child abuse at the population level had higher levels of strength, higher levels of functioning in these particular 5 areas, right? So we have this correlation between lower rates of child abuse at the population level and higher functioning in these particular factors also at the population level. The basic idea, one of the 4 basic ideas here are that the protective factors framework allows us to focus on building strengths versus trying to get rid of risks that we may or may not be able to do anything about. It's a research-informed approach, not a prescriptive model. What that means is that research informs this framework, but the framework is not designed to tell people how to live their lives or raise their kids. It's about setting a framework for practitioners to think about how we go about our work building strengths in families. It's a relational model. It allows us to approach parents and caregivers from a strength-based perspective and ask about their resilience, ask about their social connections, and help them focus on that and in a relational way. It's also aligned with developmental science in the sense that it focuses, this framework was developed, again, in early childhood education settings. So it really focuses on, not exclusively, but for the most part, on those early years of life when we know the experiences that having positive experiences and mitigating the sources of toxic stress in a young child's life is so important. Next slide, please. The 5 protective factors, I want to say a few words about the relationship between the 5 protective factors framework and cultural humility and equity. We know that in a trauma-informed system, well, I'm going to say it a different way. We cannot have a trauma-informed system. We cannot have trauma-informed care without building in cultural humility and equity as part of our practice. It's not just something extra that we add on. It's embedded in any trauma-informed system, and it's a requirement. So I want to speak for a second about how we think about the 5 protective factors framework and that aspect of a trauma-informed system. The protective factors were designed and found and seem to be found to be relevant across cultures. I haven't had anybody sort of challenge me on that or come up with counterexamples, but I'm always interested if somebody thinks that this framework does not function very well in that way. I want to know, because I'm talking about it a lot, and I'm very interested in a conversation about that. But it's designed to allow diversity in implementation. Because it's not a prescriptive model, there's a lot of room for implementing the protective factors framework in various ways, in various settings, and we'll talk about that a little bit more. Again, it allows us to engage families in a culturally humble way and allows us to focus on strengths in families. There's one other piece here that I want to acknowledge. Most of what we're going to talk about today and focus on is working together with individual families and building strengths in individual families. But we also know that we can't eliminate and reduce and mitigate the effects of structural factors like structural racism, community violence, and poverty without action at the systemic level. Today, mostly we're talking about this work that we do family to family, family by family. I just want to acknowledge that all of the sort of policy work and advocacy work also is essential for producing change. Next slide, please. Okay, let's run through the protective factors. Again, I know this will be a review for a lot of you, but it may not be for all of you. So it may serve as an introduction. The 5 protective factors, next slide, please. Parental resilience, social connections, knowledge of parenting and child development, concrete support in times of need, and the social and emotional competence of children. Let's just run through it with a working definition for each of these so that we have some common language and common understanding of how of what we're talking about here. The protective factors framework focuses on parental or caregiver resilience, especially. In general, when we think about ACEs science, mitigating sources of toxic stress, we talk a lot about resilience. That is, it's not the only thing that's needed to produce change, but it is the way that we work with families. And this framework focuses in particular on building and supporting resilience in caregivers, in a caregiving system. When caregivers are able to focus on their own well-being, they are able then to be the kind of caregivers and parents that they want to be and that their kids need them to be. We know that resilience, the most important source of resilience for human beings is supportive relationships and environments. And this model focuses on that. Next slide, please. Social connections, also a protective factor. We don't focus necessarily on making sure people have enough friends. We don't ask people, okay, how many friends do you have? If you only have 5, you need 10. It's not, the work is not like that. It's about the quality of relationships that families have, individuals in families and families as a group have with other people, other families, other institutions, right? Whatever feels to a family and like a supportive, healthy, sustained relationship that can be relied on and is mutual is the kind of connection that we're talking about. Now, I'm going to refer back to thinking about trauma recovery. What we know about trauma, one of the things that we know about it is that it interrupts when it's sufficiently strong and has lasting effects on us, it interrupts our capacity to form and build and sustain healthy relationships. This is one of the dilemmas of trauma, because those healthy relationships are the things that are the most likely to support people in their trauma recovery. And so there's a dilemma. And when we're working with folks in trauma recovery, in family support centers, families in the populations that we work with, we focus on social connections because we know that that supports trauma recovery. Next slide, please. Knowledge of parenting and child development. So here's where the idea of the protective factors framework not being prescriptive necessarily, I think, really shines. An example, and it's sort of a simplistic example, but if a caregiver of a 3-year-old doesn't know that it is developmentally appropriate and necessary for the 3-year-old to say no to every single thing you ask them to do, that caregiver is going to think maybe that they're doing something wrong, or that there's something wrong with the kid, or that something wrong is going on. Actually, nothing wrong is there. And without access to good knowledge about that and about various other aspects of child development, caregivers are at a loss. So how do we support this? What's really important here is not that we go about telling people how to raise their kids. Again, there are so many right ways to go about parenting. There's some wrong ways, and we know what many of those are, but there are many, many right ways in many, many different contexts. And what we want to do is make sure that caregivers have access to good knowledge that's relevant for them in their particular context. That knowledge may come from a parenting class that we offer, and that might be the right way for someone to learn and the right kind of knowledge for them. But that might not be the right way for everyone to learn, or the right content for everyone to learn. But as long as they have access to someone who can help them in their extended family, in their neighborhood, another community resource that provides good knowledge and parenting of child development. That's the third protective factor. The fourth protective factor is concrete support in times of need. So when we know that when families don't have access to housing, employment, food, diapers, everything else that we know basic needs are necessary, it's a protective factor for us to support families in accessing resources around those needs. We know that it's very difficult to focus on energy, for a family to focus their emotional energy and time and resources on building other strengths and supporting other strengths, although of course they're there, but they might not be able to focus on them if these basic needs are not met. And so in family resource centers, we don't provide all these basic needs, but we focus on supporting families' help-seeking behavior, supporting resources and services and high-quality service delivery in the community. Very often when families come to us, this may be the first protective factor that we work on with them, and maybe for a long time, but establishing an engaging trust with a family by providing support for them in this way helps us support the other protective factors as well. Fifth protective factor, social and emotional competence of children. So in a context of thinking about child abuse prevention, we do not think of children as being at fault in any way or contributing to their abuse, say because they weren't socially, emotionally competent enough. This protective factor is not about that at all. But the protective factors framework is about supporting the strength of the caregiving system in itself. And when a child is able to participate in that caregiving system by regulating their emotions, expressing their emotions, establishing and participating in positive relationships with caregivers and peers, regulate themselves in a developmentally, expectable way that's appropriate with expectations that exist within a particular culture. When that is supported, that is a positive input into the caregiving system and is a protective factor. So we've got 4 protective factors that are focused mostly on caregivers and 1 protective factor that's focused mostly on the child themselves. That makes us a 2-generation model. Next slide, please. Here's a little mnemonic to help you remember the protective factors. Social emotional competence of children. Thumbs up is kind of one of the first ways that we teach kids how to show us how they're doing. That can remind us of the social emotional competence of children. The index finger can represent knowledge of parenting and child development. We think of parents and caregivers as their child's first teacher. The middle finger can help you remember social connections. Middle finger should never stand alone, and neither should families. The fourth finger, the ring finger, we often wear a ring here to represent a commitment that we have made, and we want to support caregivers and parents in making sure that their first commitment is to themselves and their own well-being. The pinky finger can represent concrete support in times of need. It can't do a whole lot by itself, but together with support, it can do a whole lot, a whole hand. All right, next slide, please. So we just went over a review of ACEs. We just went over a review or intro of the 5 protective factors. I want to just take a minute and ask you to reflect. Just like and perhaps you've been through a training on ACEs before, oftentimes what happens in those trainings is we ask people to look at ACEs or do their own ACEs score and reflect on that for themselves. I want to do the same thing here with the 5 protective factors just for a few moments, because it's so important to approach this work from a personal, from a personal standpoint and really have a personal connection to what we're doing. These 5 protective factors aren't just about, those families that they work with, they don't have enough protective factors, we need to build them up. No, this is about all humans in all caregiving systems and families. If you review the list here: parental resilience, social connections, knowledge of parenting and child development, concrete support in times of need, social and emotional competence of children. And think about your own experience of that in the caregiving system where you grew up, where the strengths were in that caregiving system. Did your caregivers focus enough on their own well-being so that they could care for you? Did your caregiving family, your caregiving system have relationships that were mutually supportive? Were there areas where there were some deficits, where there were some of these strengths needed to be built? Did your caregivers need more knowledge of parenting and child development, or did they have access to good knowledge? I just want to offer you the chance to reflect on your own experiences, and not that we bring those experiences forward necessarily and talk about them explicitly when we're working with families, but having those in mind for ourselves helps us connect to the protective factors framework and helps us connect with families as they think about it as well. Social connections, looking at the chat, it takes a village to raise a child and it's okay to ask for help. Thank you, Jocelyn. If anybody else would like to just put something in the chat about what they notice in this reflection about their own experience of the 5 protective factors, you're welcome to. Okay, next slide, please. So I said that we were going to put ACEs and 5 protective factors next to each other. Let's talk a little bit about integrating them. At Safe and Sound, we're working hard to develop this idea of an integration between these, and we're working on it conceptually and maybe doing some writing about it. And we're hoping that more science can be done, more science needs to be done in this integrated way. But I really want to just spell out the beginning of how we're thinking about this. Adverse childhood experiences clearly connects early experiences with later negative health outcomes. Also, the effects of ACEs are cumulative. The higher your ACEs score, which is basically just the number of adverse childhood experiences you can count up from your life, are cumulative. A higher number means, just quantitatively from the science, means a much greater correlation, much greater likelihood of negative health and mental health outcomes later. Protective factors framework can provide a framework for how to proceed when these ACEs are present. ACEs tell you about history, but they don't indicate what to do. So, sort of at its worst, and this is a caricature, it never goes this way, but at its worst, doing an ACEs screening could be, okay, well, here's some bad stuff that happened to you and some more bad stuff's going to happen to you, but we're going to try to help. That's not really a great way. That's a terrible way to use ACEs science. What we need is, these things happen to you. Let's talk together about what strengths you have and that your family used to get through these sources of adversity, what strengths exist now to continue to mitigate these sources of toxic stress in your life, in your family's life. The protective factors framework can serve as this, can serve to do this for us. The model is aimed at preventing intergenerational transmission of ACEs. I sort of changed that idea of intergenerational transmission of trauma to say transmission of ACEs, but we know that trauma, adverse childhood experiences perpetuate across generations. Protective factors can be part of a model that aims at interrupting that intergenerational transmission. They may also be cumulative, right? We can't count them up in the same way that we do with ACEs, but the idea is that the more protective factors, the stronger the protective factors, the more mitigation of those sources of toxic stress. Also, protective factors and risk factors aren't just the ends of a continuum. You aren't a strong family or a family filled with toxic stress. It's not either or, right? They coexist. Sources of adversity and toxic stress exist. They just do. But so do strengths and protective factors. They work together. Next slide, please. So let's begin to talk a little bit about operationally how this model can work as we develop it further, and the model needs a lot more fleshing out, but we can begin to work with this already. There are screening and assessment tools that have been published that can be used to assess protective factors in families. These are the ones that I know about that are the most well-known. I think there are some more. If anybody else knows about other ones, please let us know. But just as an example, the Protective Factors Survey published by the Friends National Center for Community-Based Child Abuse Prevention, and also the Parent Assessment of Protective Factors published by the Center for the Study of Social Policy. We happen to use this, the PAPF, oh, thanks, Haley, you were really on it, putting these things in chat. I appreciate it. The Parent's Assessment of Protective Factors is what we happen to use at Safe and Sound, but I know lots of other partner agencies who use the PFS as well. And these allow us in family resource centers to use a way of quantifying caregivers and parents' own sense of their protective factors. These surveys don't score people on protective factors. It's not about me giving you this thing and me telling you what your protective factor score is. It's a way of, they're self-report, and it's a way of collecting information from a family about how they feel, what they know about their own strengths in these 5 domains. But it quantifies it well enough that you can use it to track change over time. So that's what we want to be able to do. Next slide, please. I said I would talk about ACEs screening for a minute. PEARLS, Pediatric ACEs and Related Life Events Screener, is a screening that we use in San Francisco, and it's now being rolled out across California, of course. That's a way of screening for ACEs and other sources of toxic stress. This isn't a training about using this, but I want to refer to it because I know that settings where you may be working, particularly medical settings, are rolling this out. We now have the possibility of getting Medi-Cal funding for administering this screening, which is fantastic. And part of the reason that we are advocating for using the protective factors framework along with the ACEs screening is because we've heard from so many providers that they want so much to be able to use this screening in a skillful, the ACEs screening in a skillful and useful way for families, but they feel a bit at a loss for what to do with the ACEs score. Here's your ACEs score, what do we do now? Well, it doesn't have to be what do we do now. It can, if you have a framework to back you up, I'm doing this sort of back you up in your mind. If you have a framework that you're holding in mind to back yourself up, you can then engage with a family once they have an ACEs screen, if you're doing ACEs screenings in your setting, about building strengths. Next slide, please. Okay, laid all that out for you. ACEs, protective factors, a bit of integration, thinking about ACEs screenings. We're gonna use a vignette now. I sent a vignette in to the Caltrans folks, but I may not have sent it soon enough for you to get it. Whoa, yes, you got it. Thank you, Haley, for putting that in. So I'm gonna read the vignette, but you also can access it through the link that Haley put in. And what I want you to do, next slide, please, is keep, sorry, Renee has asked a question here that's pretty relevant. Can this be used by most working with families, the pediatric ACEs screener? It is designed to be, to my knowledge, it's designed in particular to be used in medical settings, but you can be trained to use it in other settings as well. The ACEs Aware and UCAN program in California does a lot of training around using ACEs screeners, and you should contact them and look at the screenings, the trainings that they offer in using that screener, because it was designed in a medical setting here at UCSF, but it can be used in other settings with appropriate training. I hope that answers your question, Renee. Let's see, vignette activity. So next slide, please. I'm going to read a vignette, and what I'm going to ask you to do is keep in mind some of these questions. Give me 1 second. The next slide says, helps to keep in mind what are some risk factors and or ACEs for both the parent and the children in this vignette. So keep in mind risk factors, ACEs. You might, if you remember the 10 original ones or other ones. Then I also want you to think about clues that point to the potential presence of protective factors. Thank you, Katie. And then I want you to think about, if you're the person doing an, I have to sneeze, so it's going to come. Sorry, just a moment. If you're the person who's working with this family, and I want you to think about how you might begin to engage this parent in a protective factors-based conversation. So here's the vignette, and then we're going to go through, and then I'm going to show you some data from it's fake data. I made it up to go with this vignette, but how you might be able to take a look at data from the parents' assessment of protective factors, what that can look like, how you can use that in a conversation with a family, and then how you can build a service plan for a family that integrates the protective factors. So that's where we're headed. So here we go. Barbara Morgan is a 35-year-old single mother of two children, Mariana and Max. Mariana's 7, Max is 4. Barbara and her family have an open CPS case after she found out that her ex-boyfriend had physically hurt Max when he was in his care. Barbara and her children live in a room in her sister's house. The family was living with the ex-boyfriend, but after the incident, Barbara moved in with her sister. Barbara has shared that she does not let the children play outside, especially after dark. There have been multiple shootings in her neighborhood, and she does not feel safe. Barbara works full-time as a cashier at a grocery store. Her sister supports Barbara with childcare when Barbara has to work and the kids are out of school. Her sister does not have children of her own, and she lets them watch a lot of TV, but since she's the only support Barbara has, she doesn't say too much about it, even if she disapproves. Barbara is concerned about overstaying her welcome with her sister and about being asked to leave. The children attend school on a regular basis, but since the move, Mariana's teachers have reported to Barbara that she often gets into fights with other children and has difficulties completing her schoolwork. Max attends pre-K, and while he used to love going to school, recently he's been crying every time they walk into the classroom, and he refuses to let go of Barbara when they get there. His teachers have also told Barbara that Max is not getting along with other kids and often pushes them. The children's father is not present in their lives, though he does occasionally send money and gifts on their birthdays. Barbara uses the money to buy the children clothes and anything else they may need. Barbara and their father separated the first time after a violent incident that occurred between them when Mariana was a toddler. They got back together and then separated again after Max was born, following another violent incident between them. He does not have any custody and is not involved in parenting. He used to be Barbara's drug dealer, but Barbara reports she no longer uses, although she sometimes drinks after work. Barbara and the kids have Medi-Cal, and she takes them to all of their annual checkups. Barbara reports that she hasn't had time to go to the doctor, but is worried about some headaches that she gets occasionally that are sometimes so bad she can't go to work. She's been talked to by her manager about her attendance recently, and she's worried she's going to lose her job. On Barbara's days off, they try and do things as a family, like go to the park, the beach, or the library, but their car is not reliable. So oftentimes they have to take public transit and make sure they're home after dark. She barely spends any money on herself and makes sure the kids have the best clothes, books, and toys. During a home visit by the CPS worker, it was clear that the apartment is in need of repair, though no hazards were observed that would be dangerous for the children. Barbara mentions they had a roast infestation, but the landlord took care of it last week. Barbara and the children are dressed appropriately for the weather and are well-groomed. The children were excited to show off their books and toys. Mariana carried Max around the apartment and cuddled with him. When Max approached Barbara with one of his toy cars so she could play with him, she brushed him off and told Mariana to play with her brother. As the kids run off, Barbara mentions that it's hard to be patient with the kids and engage with them when she's getting a headache, and she sometimes yells at them. So there's our vignette. Next slide, please. You may have thought about some risks. I'm going to name a couple of those and a couple of ACEs that might appear, and then we're going to look at family strength and protective factors. So one of the original ACEs was violence between partners, violence between caregivers. Also, there's community violence present here, multiple shootings in the neighborhood. Also divorce. I mean, not literally, I don't think the partners were actually married, but that separation, right? So there are 3 ACEs right there for Mariana and Max. There are other sources of stress here, but I just want to name those. Let's go from there, let's put those there, and now go over here and look at what sources of strength seem to be present. I've got some that I'm going to name in these slides, but if you see others that you want to add to the chat and name, you're certainly welcome to do that. So Barbara works as full-time, she has a full-time job, right? So she's got concrete support there and with employment. She also prioritizes her children's safety and her own. She's done this by leaving a violent situation, right? That indicates parental resilience and also knowledge of parenting. She knows that situation is not good for those kids, and so she left. Next bullet, please. Again, concrete support and knowledge of parenting. She makes sure that they have access to Medi-Cal and access to medical care, and she takes them to all their checkups. Again, that's knowledge of parenting. She knows that the kids, that's a basic need of the kids, and she takes care of it. And again, and she has access to that resource, concrete support. Next bullet, please. They try to do things together as a family, like go to the park and the beach or the library, spending time with her kids, making sure that they do enjoyable things together. More knowledge of parenting. Barbara's got good knowledge here. Next slide, please. Barbara and her children live in a room in her sister's house. We think social connections. It sounds like there's some support there. The relationship between Barbara and her sister is not totally clear. It sounds like she's a little bit nervous about it, but tentatively we can name that as a protective factor. Excuse me. The children were excited to show off their books and toys. They have books and toys that engage them. I named that as social and emotional competence of children, but that also indicates knowledge of parenting on Barbara's part. She knows what they need. The children were excited to show them off, shows that they have the emotional sense of wanting to approach the stranger that was in their house in the sense of safety, right? And approach them to play with and show off the things that they have. Max approached Barbara with one of his toys so she could play with him. Again, social and emotional competence supported by what's clearly a positive attachment relationship with Barbara. She couldn't engage with him at the moment, but he did approach her, which showed that he expected to be able to engage with her and that there was a positive attachment. It sounds like Barbara isn't always able to parent them in the way that she wants. It's hard to be patient. She yells at them sometimes, basic parenting experience, but she knows to say that and think about how that she isn't always able to be at her best when she has a headache, but she knows what the kids need, good knowledge of parenting. So we can, next slide, please. We can name a lot of protective factors. So if you think about then, maybe you're a CPS worker, or maybe you work in a family resource center, if you're engaging with Barbara about building a plan to work together to support what this family needs, how can you use the protective factors and a strength-based approach in general to engage Barbara about her family, rather than starting necessarily with, okay, you had all this violence and you don't have a place to live in it. Not without that as a starting place, but rather thinking about strengths. Again, start with what you already know in this conversation. Barbara has given you a lot of information. You can see, start with her about, for example, Barbara, I can see that you really know that you need to spend time with your kids. That's really a strength. Tell me some more about the things that you do together with your kids, right? That's an invitation for Barbara to tell you more about her strength and their strengths as a family. Give referrals based on what the family wants to work on. So in the next couple of slides, we're going to look at the data from the Parents Assessment of Protective Factors, and we can generate, as folks who work in family resource centers, probably a long list of what we would want to work on with her. But coming from a strength-based way and offering trust to a family that they know, that Barbara knows what is best for her, she knows what her top priority is. That's the way we approach a conversation with her. Barbara, what do you want to work on first? Are there ways that we can support the strengths that exist in your family and support you with the needs that you identified primarily? You can ask questions. What has helped you get through the difficulties? What helped you get through those experiences of violence, right? That's a question about resilience. Where do you go for support? Who else in your life? We don't know this very much from the vignette, but does she have other friends? Does she have other support? Inquiring about that. What does your family do for fun? She already told you some of that. Find out more about it. What do you enjoy the most about your child? These are all strength-based questions that can come from a protective factors framework. What do you consider to be your personal strength as a parent? What does she know? Ask her about what she does know, not tell her what she doesn't know. What are important changes you'd like to see in your family? Notice that that's phrased in the way that is about what would she like to see in her family, not what do I think she needs to change in her family. So you can use the protective factors framework and approach families without doing it in a quantitative way, but you can also do it in a way that adds quantitative information, next slide please, to the kind of work that you're doing in your program. So Barbara completed the protective factors, parents assessment of protective factors, and here's what it looks like. You can take this, and I realized that showing a family a chart of data is going to be more useful for some families and less useful, or not useful at all for some families. For some folks, it doesn't make sense to look at a chart to explain what's going on in their family. So a model where you're using this kind of screener and this kind of information doesn't necessarily have to include, okay, we're going to complete this and I'm going to come up with some numbers about your family. Here they are. It could look that way, but it could also look like engaging, in this case, Barbara, in a conversation as you go through the screener, conversation about these different questions around the protective factors. And the numbers might sit in the background, maybe for you as a case manager, thinking about building a service plan and also using them to gauge change over time. So you might do a protective factors score at intake, and then you might do it 3 months later or 6 months later as a way to look at the work that's happened. And the way that I always try to train people in using this is that it's not about, again, it's not about scoring this family on how good they are on the protective factors. That's not going to get you anywhere. The numbers and the scores are really about how good we are at doing our job. So a change over time is about how much, how the families, how in this case Barbara's feelings and thoughts about the protective factors have changed as a result of the work that we've done. But it's not about measuring Barbara, it's about measuring our own work and how effective we're able to be and whether we need to change what we're doing or not. So if you take a look at this, just roughly, thanks. You see the scores, these particular scores go from 0 up to about 2.5. The numbers there don't mean a whole lot except as a way to compare for change over time. It's not that Barbara has to be at a 3 or she doesn't have enough protective factors, right? It's much more about comparing where the different protective factors are and looking at how Barbara articulates her experience of these protective factors. She really articulates in the green bar here that the most strength that she experiences is in the questions around concrete support, which means that she knows where to go for support if she needs it. The lowest bar, the yellow bar here, is around social connections. I mentioned earlier that we don't know much from the vignette about what her social connections are and her relationships are. The way that she completed this survey indicates that she might feel a lack there for herself. And we could use this to inquire about that. We can say, so we went through this screener and the questions that were about social connections, Barbara, seem to indicate that that might be a place that you would want to strengthen or a place that you need support. Is that right? Does that match your experience? Would you like some support from us in engaging with other families, finding places to get social connections? So you see that you don't just present this as, okay, well, here are your scores and you need social connections. You present this as, this is what this pattern looks like. It looks like you're articulating that you have a strength in concrete support and in the social emotional competence of your children. But it looks like social connections, your relationships with other people might need some support. So you can see how that's different than just presenting some numbers. So let's move from there. And I think there is a lot more to say about a nuanced way to talk with families about this, and we can talk more about that if there's time for questions and discussion later on. But I want to offer that language. But let's move to, okay, well, how do you take those scores and this conversation that you've had with Barbara and develop it into a service plan that can be used again to support her priorities and her needs? These are services and goals that I've made up, of course, to go with the vignette. But Barbara, you can kind of hear and see in the vignette that housing, she's got a place to stay, but it doesn't feel super stable to her and she's worried about it. So that's top priority for her, secure, safe, permanent housing. We connect that goal of Barbara's directly with a protective factor. All the goals that a family articulates are going to connect to a protective factor. It's a broad enough framework that almost everything a family wants to do and work on is going to be related to a protective factor. We're just going to name that in the service plan, and we're going to talk about that or offer that with Barbara. That's a concrete need. We're going to work on that. And then there's room for sort of services that support that goal. Connect Barbara with a housing agency and support her with the application process. These are activities that are familiar. The protective factors framework isn't about doing work that's different than you've been doing. We already do this work. It's about putting a framework around it that allows us to support sort of tracking the outcomes, to support knowing how effective we are in our work. A second goal might be securing medical care. she articulated that she doesn't go to the doctor very much. And we might want to talk with her about, well, Barbara, you have Medi-Cal and your kids have Medi-Cal. Can you get to the doctor? Do you have these headaches? Is this something you want to address? She may be reluctant to go to the doctor for a whole variety of reasons. We don't necessarily know what they are. Her experience with the medical system, she may have had a negative experience with that, and she might feel reluctant. It's not our job necessarily to convince her and tell her she has to do that, but you can offer and say, it sounds like you've got access to medical care potentially through Medi-Cal. What about making a visit to the doctor for these headaches a goal? Maybe we can accompany her, right? That's also a concrete need. Access to resources, supporting access to medical care. Social connections appears, but it's down the list here on this service plan. It was the lowest score, and if you looked on the data from the PAPF, and if you looked at just that, you would say, oh, well, we have to work on social connections first because it's the lowest. That's not necessarily the case. That's just a suggestion, right? We do want to offer that idea to Barbara and let her and support her in prioritizing it where she thinks it belongs. Maybe the Family Resource Center where we work offers family events and we invite her to an event. And maybe she has a goal for signing up for 2 family events in the next, 6 months or even a year. And that connects to social connections. Knowledge of parenting, increased use of positive discipline. Barbara's obviously interested in and thinking about the way that she disciplines and approaches her kids. Does she want to attend a triple P class? Maybe she doesn't. Maybe that's not the right kind of venue for access to knowledge of parenting and child development, but maybe it is, and suggesting that to her, and if she wants to do it, connects with knowledge of parenting. So what we see here is connecting a family's own goals as they articulate them with the protective factors. But what you don't see here is all 5 protective factors on the service plan. You don't have to work on all 5 protective factors. You just need to work on the ones that the family prioritizes, right? The protective factors framework isn't about, okay, we're going to impose this framework and we have to work on all 5 of these. It's a framework that allows us to think together with the family about what they need. Okay, next slide, thank you. Okay, so there's a brief description of how we can implement the protective factors and sort of ACEs framework together. That's just a summary, and there's a lot more nuance to it, of course. And implementing that in the setting where you work takes a lot more of sort of change management and technical work. So I want to talk a little bit about just one way that we at Safe and Sound have tried to sort of disseminate this and support other family resource centers in San Francisco who do want to implement a model like this. It's called the Communities of Care Project. It's a 4-year project funded by the Doris Duke Community Foundation to allow the Safe and Sound team to provide support, technical assistance, and training to our partner agencies that want to implement the protective factors framework in a more intentional, more outcome focused, more operational way. The purpose of the project overall is to support the whole network of FRCs in bringing together over time, bringing us together around a more common language, a more common set of outcomes, the protective factors framework within the San Francisco FRC network. In the project, we provide foundational protective factors training, customized coaching for family resource center teams, networking and peer learning opportunities for participating agencies. So I say this not as a commercial for Safe and Sound and what we're doing, but just as to name that this is part of building this community pathway within that larger context of reform that Katie describes to us earlier. We've had 8 FRCs participate so far. Hopefully we're going to get through the whole network over a bunch of years. But again, if we go out from that individual child family level in the ecological framework out to the community level, we can participate together as family resource centers in unifying the work that we do to strengthen the web of support for families in our communities. Okay, next slide, please. There's a little bit of, oh, we're right on time. That's great. I want to offer just a minute for you to think about how an integration of ACEs science and the 5 protective factors framework might be useful in your program with your population. If you'd like to add something to the chat about that, perhaps you've already begun this kind of work, this kind of integration and using this framework. Really interested to hear from you either in the chat today, or if you'd like to communicate with me or Katie about it and engage, be very much happy to do that. This framework can be implemented in a little FRC that's like 2 or 3 people in a storefront in a town, or it can be implemented in a much larger organization as well, like Safe and Sound or other. It's scalable. Really, it's about supporting practitioners and having the framework in mind and embodying it in the work that they do, and then also using tools like these screeners to collect some data that can be used to track change over time, to strengthen even further the work that we do with the protective factors with families. You're welcome to consider this for yourself. Add it to the chat, or communicate with Katie or me further about it in the future. Next slide, please. So, Katie, I think I'm turning it back over to you. We've talked about this, these 2 inner circles, working with the child, working with the family, and a little bit of the community. Let's go back out to that community level and talk about community experiences of adversity and community level protective factors.
Thanks so much, Malcolm. Every time we're in conversation together presenting, I always learn so much. And I'm really grateful to you and grateful to some incredible comments in the chat. We look forward to, we have about 10 more minutes of our conversation. Please feel free to add anything into the chat or the Q&A. We're happy to be able to answer them with you. I did want to spend the last part of our time together talking about, we started at the outer circles, talking about systems change and policy, thinking about what that paradigm shift looks like to go from community mandated reporting to community supporting, really think about the evolution of that community pathway. Malcolm took us on a journey of what it would look like at that inner ring to protect and build protective factors to support and strengthen families, and very operationalizing of that, thinking about with the underscoring and basis of adverse childhood experiences at that individual level. So I'm going to take us just out to that community level work and continue the conversation around adverse childhood, adverse community experiences, and really end on what can we do is where I want to go. Thank you so much. It's good to see some of these comments in the chat. And what we hope is that this helps you at an everyday basis in terms of doing your work. So you may be working directly with families and really focusing on those individual outcomes. You may be doing more community level work, working on community outcomes, or at a policy and systems level work. And what this ecological model does is it allows us to see that we're all interconnected and we all really have a role to play in it. So Malcolm talked about adverse childhood experiences, and research also shows, and there are here the adverse childhood experiences that Malcolm talked about, child abuse and neglect, as well as maternal depression, substance use, domestic violence, homelessness. Those are this is sort of a tree or a pear of ACEs. You have these individual level, but research also shows that you have these community level root cause adverse childhood experiences: poverty, discrimination, community disruption, lack of opportunity and economic mobility, violence, and poor housing quality. And we certainly saw those examples in Barbara Morgan's situation, where these conditions in communities were impacting her ability, her sister's ability to be able to care for their children. And what the research also suggests is we don't just have, similar at the individual level, it's not just thinking about the risk factors, the adverse childhood experiences, but it's also important to think about the community protective factors. And the Center for the Study of Social Policy has begun research in this area, really to identify what are the community protective factors that are so essential to create that condition in which children and families can thrive. They've identified these essential basic needs: racial social justice, social support and connections, as well as that important social contract. What are the agreements that we have with each other in terms of being a cohesive community and a cohesive society? I want to focus, because it's so important and it's been mentioned in the chat several times, about the importance of those basic and essential concrete needs and concrete supports. So research shows that when we increase economic supports, we see a decrease in child welfare involvement. This is happening across many, many different interventions, whether or not it's differential response or alternative response, depending on what it's called in your jurisdiction. Family preservation, concrete supports that you can see around housing and Medicaid and paid family leave, legal supports, economic supports like minimum wage, etc. Anytime you increase these economic supports, you're seeing a decrease overall in child welfare involvement. And similarly, anytime you reduce those economic supports, you're seeing an increase in child welfare involvement. So when you reduce TANF benefits, when you increase gas prices, when there's increase of housing instability, that's when you're seeing pressure on child welfare involvement. And if you go back to the 5 protective factors, that makes sense. The more stress you put in families, the greater the likelihood a family is to be stressed and there to potentially be a child welfare involved matter. There's so much data here. It comes from the incredible work of Chapin Hall. We are going to give you these links so you have it. But if there are just 2 data points of all this research that I just shared with you that you could walk away with, I think the 2 most important ones are, for every $1 increase in minimum wage, there is, research shows, a 10% reduction in neglect reports. Anytime there's a $1 increase in minimum wage, we're seeing a 10% reduction in neglect reports. Other research says that when there was an increase of $1,000 or 13% in a per person spending of poverty across all programs, we're seeing substantial fewer children reported for maltreatment, who are victims of child abuse, victims of entering into foster care, and fewer children dying each year. And so this is research that is relatively recent and important to think about as we're working at that community-based level, where we can put our support. And I know that there were chat comments earlier on talking about the importance of family resource centers, and certainly family resource centers are critical in terms of being able to provide the support. So we said it at the beginning, child abuse costs, but prevention pays. And there is substantial research that shows both the importance of the return on investment between almost $3 to more than $4 return on investment for every dollar spent in prevention programs. Family resource centers in particular yields a substantial return on investment. And you can see the same with home visiting programs. This is data from the Nurse Family Partnership, as well as parenting education programs. So we are going to close up our session now. Happy to answer any questions that you may have. And hopefully you've come away with a place where you can intersect with prevention, whether or not it's at the individual level, at the community level, or at that systems level. And we are happy to, I'm going to turn off the screen in 1 second, but here's our contact information. Please feel free to get in touch with us. And we're also contacted through Caltrin. Thanks so much.
Great. Well, I know that we're going to start seeing it in the chat, all of the thank yous from participants and how grateful they are for the information that you shared with us today. So thank you for that, first and foremost. Also, as these are scrolling on through in just a moment, we're going to drop a survey link. That survey link is going to be a brief, short survey about your experience today, participants. And at the end of that survey, you'll have access to your certificate of completion, your certificate of attendance, if you will. Haley has dropped that into the chat. And I know that there's going to be a lot of wonderful accolades in the chat as well. So we might have to drop it a couple of times. And with that, we just want to thank you both for being with us. We hope to see you again. And thank you all for joining us today.